Hello, and welcome to this presentation about wound management in the emergency department. My name is Kelly, and myself and my co-author work in two hospitals. One is a major academic teaching centre in Dublin, with an ED hosting about 45,000 visits each year, and the other, just down the coast road, is a smaller but affiliate centre hosting about a third of that. So a tale of wounds in two hospitals. And while this is hardly Paris and London in the 1700s, a Dickensian analogy might have value in terms of the best of times and worst of times. You may have heard of the Celtic tiger. This study spans both pre- and post-tiger. Many know the lush Gaelic green in the Irish flag, but fewer know that the orange represents the followers of William of Orange, originally the stadholder of the Netherlands, with white being the aspiration for peace between them. This symmetry is attractive for a conference here in Amsterdam, but perhaps also a useful symbol for trying to bridge the gap between a budget made of €100 bills and a leaner one of 50s. What makes wounds a particularly good lens through which to see ED management in changing times? At any moment, 1.5% of the population have a wound. This not only poses a significant impact on a person's well-being, but occupies 4% of total healthcare costs. And in the ED, our data would suggest that wounds are involved in 11% of presentations, placing it squarely between abdominal pain and chest discomfort in terms of frequency. But what makes the wound challenge really unique is that, while they require skilled immediate intervention, rarely hospital admission. But, unlike other common non-admitting complaints, they also require skilled ongoing care, about 4 visits on average. How do hospital departments deal with ongoing wound care in both green and lean times? Not long after the economy worsened, community public health nurses began refusing referrals from patients who did not have a medical card. In the larger hospital, this put surgical inpatients in particular trouble, with discharges being delayed for wound plans which might involve paying a GP each day or teaching family members to change dressings. You can imagine, for example, in a young person with a pilonidal abscess, this is really not optimal. The emergency department once brought its wounds back, about 1,500 visits annually, but after the crash, they also tried moving this care into the community. However, it was only possible about a third of the time. In the smaller hospital, years ago, when the emergency was still a casualty department, the nun who ran the unit offered a wound service for discharged patients. It grew, and by 2010, the department was seeing about 3,000 visits annually, with just over half coming from the emergency department, 40% as surgical discharges, and just over 5% as medical discharges. The service now has a dedicated space within the department. It's run by 2 tissue viability nurses who have direct access to clinics, tests, and emergency doctors, and even surgical admitting teams. In 2010, we undertook a pilot to move ongoing wound care from the large emergency department to the small one. In stretching this service, white became the predominant color. It was indeed an exercise in goodwill and cooperation. Within 2 years, there was a 99% reduction in ongoing wound visits to the larger ED, but only a 15% increase in the larger service. About 1,000 visits per year have moved. And costs? The average visit to the ED costs €279. It would be a push to call these average visits. Having it translates to 138,000. Making it a third is on balance probably too much of a push. The real savings is likely to be about €100,000 annually to the larger hospital. What about quality? The government has produced national guidelines for wounds. That includes an audit tool. We were the first department to use this tool in a multi-center study evaluating these 2 hospitals and also a public health clinic. It's ongoing, but the initial results are startling, with the larger hospital scoring 17% and the smaller 71%. Now, if you don't ask the right questions, every answer seems wrong. And while we were expecting a difference between the 2, this answer still seemed wrong. A closer look at the audit tool showed it largely assessed documentation, rarely clinical outcomes such as closure speed and recurrence rates. The wounds in the larger ED still healed. In fact, most of the time they were being treated by the same nurse, one with years of wound care experience, but a holistic approach to documentation was only done in extreme cases. That said, documentation is important. In fact, our project has received a grant to help develop a tablet-based system which, without even thinking, would comply 100% with the guidelines, but also create a facility to start tracking some of what we would consider the more interesting questions. So in conclusion, our pilot has successfully relieved the larger emergency department of its wound care management and provides a higher quality of care despite the stormy economy. So how does this tale end? Does the small hospital start sending its wounds back to the big ED? Or do they expand what is a great service even further to include surgical patients from within the group who have also had their care cut? That might take a bit more than just goodwill. Perhaps in these stormy times we can look for a bit more Dutch inspiration. They have a long history of harnessing strong winds for useful work. I found this windmill to bring back to our wound clinic. It also holds a perfume candle, because if I can tell you one more thing about ongoing wound care, it's that an air freshener can come in quite handy.